Hello, I'm Alison Holloway. I'm a UK registered dietitian specialising in working with people who are neurodivergent and have chronic health conditions and/or disordered eating. And I'm delighted today to speak to you on the topic of food fear and dietary restrictions, a compassionate and safe approach to disordered eating. I don't have any disclosures to make. And just to run through a little bit of what we're going to cover today, we're going to talk about triggers and the development of food fear and restriction, a little bit about eating disorders and disordered eating and how they might relate to Ehlers-Danlos Syndrome, recognising eating issues in yourself and as a professional, a little bit about self-care and about risk management and identifying risks, and also a note on misdiagnosis, and then we'll finish with a case study to bring it all together. Now, it won't be lost on anyone in the room here that the triggers for food restriction in Ehlers-Danlos syndrome are really complex and interrelated. And I think this diagram just gives a little taste of how many different things can affect our ability to eat with Ehlers-Danlos syndromes. And I'm just going to go through a few of these as part of this presentation, in particular looking at eating disorders, physical issues, psychological issues, and a bit about prescriptive diets and neurodivergence. So let's look at Simon. Simon is autistic and he has some sensory differences due to his autism. He really does not like slimy food that's inconsistent. And that means he can't eat very many fruits and vegetables. When Simon was 15, he decided to become vegan for ethical reasons. And that cut out another great big lot of foods that he could eat. At about 20, Simon was then diagnosed with hypermobile EDS, and he was complaining of some lower bowel symptoms, particularly constipation, diarrhea, and bloating, and went to see his general practitioner, his primary care doctor. The doctor advised him to follow a low FODMAP diet, gave him a diet sheet, and sent him on his way. Now, Simon is very diligent, and he followed this diet sheet to the letter. It didn't resolve his symptoms, so he's still got these lower gut symptoms, but he carried on with the low FODMAP diet because he didn't get any information on reintroduction or what to do if it didn't work. He then started to have some problems with his jaw. His jaw was sort of cracking and clicking and painful. And that meant that he struggled then to chew, particularly chewy foods, crunchy foods. And he had to cut those out of his diet as well. But he was still also having these gut symptoms, this bloating and diarrhea and constipation. He went on some forums online, and on those forums, people advised him that actually he should try a low histamine diet and that might well help. So Simon was sent a diet sheet from one of these people on the forums to follow. It's very complicated. He worked his way through it and diligently followed it like the low FODMAP diet and excluded all the high histamine foods. It didn't resolve all of his symptoms. It did help with some of them. So Simon now has a very restricted diet. He's still following diets that haven't worked fully for him. And he's increased his food fear and his reactivity to food through absolutely no fault of his own. It's not his fault that this happened. So his food intake and his variety of food has gone down. And actually, when you look at this, if he had been given advice at the beginning on expanding food, he might have actually done better with his symptoms than in restricting food. And for Simon, this developed into a cycle of food fear. So he had symptoms, he avoided suspected triggers, which is what you'd expect someone to do. He got some relief, not full. But then he started to look more at his body and to think more about what was happening when he was eating, noticing signs and symptoms, both during eating and for some time afterwards. And his fear of eating increased. His nervous system was really activated, which is normal when we feel under threat. And his symptoms and reactions increased. And again, this becomes a cycle until it's broken. So thinking about some of the things that impacted for Simon and for other people with Ehlers-Danlos syndromes, neurodivergence is one of those things. Now, I'm not going to go into great detail here because Mel is going to be doing a presentation later all about neurodivergence. But just to mention things like sensory needs, interoceptive differences, executive function, and pathological demand avoidance are all things that can impact on dietary restriction for people who are neurodivergent, and certainly impact on the way dietary advice is given as well. Prescriptive diets. Now, this is a big bugbear of mine as a dietitian because they're often given out a bit willy-nilly and not really thought about the impact for the individual. They might be given by health professionals on forums or by friends and family even. And there are often multiple overlapping dietary restrictions. They can then be exacerbated by trends related to food on social media or even traditional media, things like paleo and ultra-processed free, for example, and lead people to have very, very restricted diets. And I think the key message here is that, restriction should be avoided where at all possible. There are very few reasons why people need to be on long-term restricted diets. There are a few, but there are not many. So when trialing diets, reintroduction is absolutely the key, unless, of course, you have anaphylaxis, in which case reintroduction needs to be done in a hospital setting. There's physical and psychological factors impacting here. So for Simon, it was his jaw, but also other conditions like POTS and MCAS can impact on this, other physical symptoms like IBS and things like compression syndromes like MALS as well, and gastroparesis, as well as psychological factors like food fear and fear of contamination, and practical aspects caused by disability. So, having difficulty cutting up food, shopping, and of course the financial impact of having a long-term chronic illness as well. Food restriction and eating disorder aren't the same thing. So eating disorders is something completely different, really. They're interrelated, but an eating disorder is a serious mental health condition. It has defined criteria for diagnosis, which is set out in the DSM-5. And this diagram just gives a little bit of a summary of that. So we've got restrictive eating disorders like anorexia nervosa and avoidant food intake disorder, avoidant restrictive food intake disorder. We've got binge eating disorders and other specified feeding or eating disorders. So anorexia is restrictive and is based around fears around body image and about weight gain. ARFID is not about weight and body image usually. In bulimia, you've got binging and purging, and binge eating disorder, binging without purging. And then other specified feeding or eating disorders, which people haven't heard of quite so much, is just a term that encapsulates often eating disorders that don't quite fit into those categories. So maybe purging without binge eating, for example. So as it's a relatively newly defined disorder, I thought I'd talk a little bit more about ARFID, and it's very relevant to the EDS community, this as well. So it's not a new condition, even though it's newly defined. It's more common in people who are neurodivergent, but not exclusively. And there's three main subtypes: sensory, so sensory differences; fear adverse consequences, so for example, a fear of being sick or a fear of pain; a lack of interest in food, so just not caring about food at all. And to be diagnosed, it needs to lead to significant nutritional or psychosocial consequences. There is limited help and services, certainly in the UK, and most of the services, I would argue, are aimed at children and not adults with ARFID. It is changing. I've seen commissioning of new services for adults across the country, so watch this space, I guess. There is 4 times the risk of needing nutritional support in people who have fear-based ARFID and hypermobile EDS. So that's really significant, and something that as professionals and as individuals we should be thinking about and looking out for. So do eating disorders and EDS have common risk factors? Well, looking at some of the risk factors for eating disorders, you could argue yes. Particularly risk factors such as gender, so more people who are assigned female at birth have eating disorders. There could be some bias there. Autoimmune inflammatory conditions, gastrointestinal disorders, particularly disorders of gut-brain interaction like irritable bowel syndrome and functional dyspepsia been linked with eating disorders. Neurodivergent, so ADHD being linked with binge eating disorders, and autism and OCD being linked more with restrictive disorders like anorexia. And then dietary restriction within the family and involvement in elite sports. And I think dietary restriction in the family is worth mentioning because EDS are inherited genetic conditions. So if you are restricting as a result of your EDS, it's worth thinking that that restriction could actually increase the risk of eating disorders within the family. And it is really worth thinking about that, taking care. Is the incidence of eating disorders higher in people diagnosed with EDS? maybe. The research is lacking, I would say, in this area, and it's when you look at the research, the variety is huge in the figures, but for screening for eating disorders like ARFID, for example, the risk was about 30% in people with EDS compared to 3% in people without. The risk scores aren't perfect because they are not designed for people who have chronic illness, for instance. So that's a downside of that information. There is more of a link with these disorders of gut-brain interaction, as I've talked about before. And it's a bit chicken and egg because eating disorders cause gastrointestinal problems. There's more eating disorders with gastrointestinal problems. There's more gastro problems with EDS. So it's a really, really complicated picture. So how does disordered eating fit into this? So disordered eating is used to capture difficulties with food and eating and behaviours and thoughts around that don't fit in an eating disorders diagnosis. Disordered eating doesn't imply any sort of blame to an individual. None of this is anyone's fault. So whether you've got disordered eating or an eating disorder, that is not your fault. There's so many things that lead to struggling with food. It can represent the start of an eating disorder or the continuation of a previously treated eating disorder, or it could be completely separate from eating disorders altogether. And it's really important to say that eating differently from the norm is not inherently disordered. So I have had referrals in the past where people's cultural norm for eating has been misunderstood as disordered eating, for example. So how do you know if it's an issue for you? Well, I would say the first thing is if you're asking that question, you're probably a little bit worried about it, and that might be a good time to seek support from someone who's experienced in looking at disordered eating and eating disorders and chronic illness. If you are, intentionally narrowing the amount of foods that you eat, you're worrying about your body shape, you're taking medications or products to lose weight that aren't prescribed, and you are not able to eat in front of other people, that might be some indicators of difficulty. But if you're worried, I would say that get that assessment really, because particularly in EDS, all of these things can be a result of the actual illness itself and not disordered at all. If you are worried, see your primary care doctor in the first instance. They may take blood tests depending on risk and refer you on to a specialist. I understand that it's not that easy to see a primary care doctor at the moment. So you may want to seek out the support of a registered dietitian or appropriately experienced and qualified nutrition professional instead. Or some charity and not-for-profit organisations as well can help give you some support. Just a note on self-compassion. Whatever the struggle, whatever the cause, none of this is your fault and you deserve expert care. You are not the same as everybody else. We're all unique. Where possible, stay away from spaces that make you feel worse or that suggest further restrictions. Seek compassionate support and start just with small changes. So if all you can manage is one brand of cracker, then have more of those crackers until you can see somebody that can support you with reintroducing food. If you're a health professional, listen to your patient. Always work within your scope of practice. Do an assessment if you can with validated tools, but know that they are not the be all and end all. And actually, looking at the patient is much more important. Assess and manage risk or refer to somebody who can really urgently. And be aware of your own biases. Just because someone is overweight doesn't mean they haven't got an eating disorder. Just because someone is male doesn't mean they haven't got an eating disorder. If you suspect an eating disorder, refer to specialist services as quickly as you can because, the evidence is that early referral helps and people are more likely to get a resolution if they have early referral. Whatever the cause, whatever you're thinking, malnutrition needs to be treated. So whether it's an eating disorder or EDS or whatever, it does not matter. Malnutrition should be addressed because that is the bit that's dangerous for people. As well as this, listen to the whole team. So if someone has got other doctors or professionals involved in their care, whether they be private or NHS-based, if they are experts in that chronic condition, it's really important to listen to what they've got to say about that as well. In the UK, there are guidelines for managing high-risk situations with disordered eating and eating disorders, which are the MEAD guidelines, the Medical Emergencies in Eating Disorders guidelines. And the biggest risk here is refeeding syndrome, which is a shift in electrolytes in the blood when people start to eat again. And the biggest risk really is for very low weights and very restricted diets of 500 calories or less. So these are the things that professionals should be thinking about and looking at when they're assessing risk. Just a note on misdiagnosis. So this happens more often than I think we would like to happen. There is a risk of profiling here if you've got your tall, slim female, young, arriving in clinic, refusing to eat and losing weight. There's an assumption that that's an eating disorder. And actually, that could be because of symptoms of a condition. So they might have gastroparesis, they might have a compression syndrome like MALS and experience a lot of pain with eating. And that's why they're not managing to eat and why they're losing weight. There's a lot of overlapping symptoms. So you'd have seen in the MEAD guidelines, some of the assessment is around autonomic function and muscle weakness. Well, those of us with EDS or hypermobile EDS are going to have those symptoms potentially anyway, and it won't be as a part of an eating disorder, or they might get worse if you do have an eating disorder. Diagnostic overshadowing, so past history of eating disorders, anxiety or neurodivergence can lead people to make assumptions that it is an eating disorder as well. The other thing to mention is differences in describing and communicating symptoms, because if people are neurodivergent or if people have had previous medical trauma, they might share or describe symptoms in a different way. And that can lead professionals sometimes to make assumptions about them or to not believe what they're saying. Always use the correct diagnostic criteria. They exist for a reason. And actively listen to the patient and the family and professionals already involved in their care. If you don't know about chronic illness, then find somebody that does. So just a little case study to finish off. We've got George here. He's a young adult. He's got the trifecta of HEDS, POTS, and suspects MCAS, and his mum's worried about ARFID. Their goals are to expand the range of foods he has and prevent further weight loss. So at his initial appointment, he was found to be having one meal a day due to fatigue. He forgets to drink and feels full quite quickly, dislikes slimy textures, and is currently on 5 foods a day. A risk assessment showed his BMI was 20, which is its lowest. It was previously a BMI of 23, and it's been stable for a month. Trauma means he's got a limited relationship with other professionals and can't tolerate blood testing. We explored the foods he likes, and found out that he'd got particularly a fear of anaphylaxis. In the risk assessment, the difficulty was not being able to get any blood tests to check what his electrolytes were doing. So the plan was to have a vitamin and mineral supplement, contact his GP, work urgently with his therapist on medical fears, and move drinks away from mealtime and split his meals into smaller eating episodes. At the follow-up, his GP had been in contact. He'd managed to split food into 2 episodes, which helped with his fullness, and he'd had some increase in fluids. We explored his fears more and gave him a chance to ask lots and lots of questions. He started to introduce protein of a texture that he likes, so crunchy protein sources, and milk. We discussed nutritional supplements, but he disliked the taste and texture previously, so we adapted the taste and texture and took away any pressure to try those. So at follow-up, he was feeling more confident with food, less worry, finding it helpful to be able to ask lots of questions, managing a small amount of protein at meals, managing a glass of milk a day and 1 supplement a day made into ice pops. He continued to build protein portions and add a glass of fruit juice or fortified squash, because vitamin C is one of the nutrients that's most likely to be deficient in people with restricted diets. He gained 0.5 kilogram, which was great. He was eating 2 meals a day with protein and carbohydrate, 1 juice and 1 milk drink on most days, and 1 supplement drink most days made into ice pops. We continued to encourage and support him to get blood work done and to work on the quantity and balance of food intake within his sensory needs. This wasn't an ideal situation, so there was some risk to carry when medical care is patchy and when you can't get blood tests, and it's important to clearly communicate that. For George, we were able to assess his risk, earn his trust, and provide compassionate and neuro-affirming care. We discussed referral on because I can't diagnose ARFID as a dietitian in the UK, but I can treat the consequences. And hopefully it's a stepping stone to him being able to manage further care now that he has had somebody who is somebody that he felt he could trust. And I guess the key message from all of this to finish off with is that fed is always best. So healthy eating is when you're healthy, but fed is always best. So whatever you're eating, it is better than not eating anything at all until you can get the appropriate care. So a little bit of information on support groups there. And thank you very much for listening to my talk today.